Okay, so first of all, we're going to watch a video, and I want half of you to find the good things that she does, and the other half to find the bad things. And then we'll talk about them after. Who is feeling positive today?
I'm feeling amazing right now. Because of Margaret.
Because of Margaret. Okay. Can you guys be positive? You guys be positive. You guys be negative, and we'll switch. We'll keep the same for the next one because we'll have a harder job than another. Also, apologies about the American accents, but they're quite good videos. So. Oh, write your things down.
Hello, ma'am. Miss Flores?
Yes.
So, what's your body been telling you?
Well, I get very tired. I get some dizziness when I get overly tired. I have a lump. I'm scared. I want to know what the results of the test were.
Well, the reason we've been doing these tests, the CBC, the Comprehensive Metabolic Panel, the mammogram, let's get right down to it. Mrs. Flores, you have invasive breast cancer. It's metastatic to your lymph nodes. It's estrogen receptor positive, which is a good thing because you will respond to hormonal therapy.
What? I can't have cancer. No one in my family has cancer. Are you sure?
The next step will be for me to send you, or for you to meet with a medical oncology team and a general surgery. They will probably recommend a mastectomy, a lumpectomy, and this will be followed by radiation therapy and chemotherapy. Do you have any questions? Have I gone too fast?
Oh, I didn't understand. All I heard was breast cancer.
Yes, sorry. You have a tumor, a growth. It's serious in that it can spread and it can grow pretty quickly. So it's been very insidious. Any more questions?
How can I have breast cancer? I kept all my mammogram schedule. I kept my checkups.
So your cancer has been very insidious. It was undetectable at stage 1, and breast cancer is very prevalent in the Hispanic population. You know what I need for you to do is just to remain strong.
I have breast cancer.
Yes, I know. That's the way nature is. I think I'm just going to refer to the medical oncology team at this point. But you know, Mrs. Flores, I know you can bounce right back from this. You're very active.
Am I dying?
No, you're not dying. You have plenty of treatment options available. In fact, I'm sending you to the best medical oncologist in town. I guarantee you're going to be fine.
I'm scared, doctor.
You know, you're going to be fine. There's plenty of cancer survivors everywhere. In fact, my Aunt Marie, she was diagnosed with breast cancer and she is doing fine.
I don't want to be in pain like my husband was.
Like I said, you're going to be all right. I know just how you feel.
I've seen what cancer can do to you. Eats you up. My husband died of colon cancer.
So you know what the harsh treatments that are going to arise and the issues. You know, I'm available to help you. Why don't I set up a meeting with you in a couple of months, say 6 months?
Breast cancer.
I'm sorry, yes. You know, I'm going to call in my nurse practitioner, Bonnie, and she'll be available to answer any questions. You can take your time. Here's some tissue if you need some. Let me go call her now. Here. Okay? I'll see you in a couple months. Bonnie.
So long.
whoever gives me something good gets the treat tin so they can give Margot a treat. I'm an alternative teacher. So, for those of you who's just joined us, we are, I didn't actually say who I was, I assume everybody knows. I'm Nikki, I'm one of the geriatrics consultants. We're doing a session about Breaking Bad news, and you guys are going to come up with a crib sheet of your top tips that you can share amongst the F2 group. Although, actually, there's loads of you here, which is really nice. Okay, so we're going to try and make some positive things. Let's go the easy half first. Guys on this side who being the negative ninnies, what did she do wrong?
There were a few things.
Kept the bleep on.
Yeah.
Yeah, so we want to get rid of distractions. Yeah.
She kind of just went straight in. There was like no signposting or preparing. She just kind of said it very directly, and then like information overloaded.
That's a lot of things. Signposting. What do we think about signposting?
It's important to give a warning shot so that people are aware that you're going to tell them bad news.
Yeah. Need them to be prepared. Quite often though, I think that we do it in our manner of setting up the conversation. And some people get pissed off if you pussyfoot around. They just, like she said at the beginning, I just want to know what my test results are. She did kind of try and say, what's your body been telling you? She was trying to make some rapport. Yeah. So maybe, but not too much signposting. Don't beat around the bush. And then what about information overloading?
A lot of medical terminology.
Yes. Quite often when people are hearing bad news, they don't take much of what you say in. Like at the end, did you see that she said, breast cancer? It was all she took from that. But some people are going to want a lot more information to start off with. So you can kind of try it, you can ask them, what level of information do you think you're able to take in right now? What level of information do you want from me? Yeah? Jargon, definitely. Even if you're talking to another healthcare professional, I didn't understand what half the words she was saying because she was talking American. I think if I was talking to a breast surgeon, I'd be like, I don't understand half the words they're saying. Okay, what else did she do wrong? Anybody else at the back who came in at the end who wasn't assigned a positive or negativeness can...
I was going to say false reassurance. I think at one point she said, I guarantee you'll be fine. Just lying to the patient.
Avoid false reassurance. Do not lie. Yeah.
Body language and positioning. She was sat above the patient with a clipboard in between them.
I'm not going to teach you guys to suck eggs. You already know about, you've had millions of OSCEs about like making sure that you provide a nice safe environment and that you're not making the person feel threatened by not standing over them. I quite often sit next to my patients, even when I'm not breaking bad news, or sit on the bed and pull the curtains so that the matron doesn't see me do it. It's much better for rapport. Anything else you did wrong?
Just acknowledge the patient's fear.
Just well acknowledge. DG.
Oh, I'm dyslexic, aren't you?
Something like that.
Looks right.
I'm going to add something else there about cues. So people, when you're having difficult conversations with them in your personal life or at work, might drop little hints to you about what they actually want to talk about. And if someone mentions something more than twice in a conversation, they probably want to talk about it. Did you see what she mentioned a few times?
Her husband.
Her husband. She might do better at that than in the next video, maybe. I'm not sure. But if you they've kind of surveyed healthcare professionals about why they don't follow patients' cues in these conversations, and they feel it will take them off course, so they won't give the information that they're trying to get out of their head to the patient, and that the consultation will take longer. But actually, when they you can't double blind it, but when they randomised people to either following cues or not, the conversations did not take longer, and the patient was more satisfied and retained more of the information they were given afterwards. So following the cues is scientifically good for us. So the fact that she mentioned her husband a couple of times, why don't you prompt to say, tell me about what happened to your husband, because she'll tell you a lot more about her fears and what she's worrying about that you can address if needed. Anything else she did wrong?
She brought in her own experiences about her family.
I know how you
I
feel.
said, I know how you feel, which is like, one, you never know how someone else really feels because it's a different scenario. And two, she's not the one that has cancer anyway, so the doctor is a patient, so it was just quite very inappropriate.
What do we think about bringing in personal experience to these conversations?
Sometimes it can be beneficial, sometimes it's not.
I think it depends on the clinician and how comfortable they are. Because if it's not something you're comfortable with and you do it, then it will be really awkward. And it depends on the rapport you have with that patient too, and kind of judging with them. So I wouldn't necessarily say that sharing your personal experience is a bad thing that you should avoid, but definitely patronising. She was also really racist. But I don't think that you guys need that one.
Hispanic.
Yeah, she was like...
Was she Hispanic, the patient?
Yes, the patient
Were they
was
supposed to be Hispanic?
Well, she might have, her husband might have been Hispanic and she had a Hispanic surname, but... but I'm not going to write that one down because you guys know that. Anything else that she did good?
Anything that she did good?
Yeah, oh, so we finished with bad things? Anything else she
I was
found?
going to say as well, inappropriate follow-up, she said 6 months, and also she inappropriately delegated to a nurse to answer questions.
Oh.
That's going to need
Off you go.
Organise appropriate follow-up. And I'm also going to add to that that might not just be the medical follow-up that she needs, like, to see the surgeons next week or whatever. It might be that you need a follow-up on the Breaking Bad News conversation. So to organise another time when they can ask you questions. You might also want to offer to have conversations with any family members. This is especially important and complicated in younger patients who might have children, and then it gets really complicated and you might need to ask someone else to help you with. I would suggest signposting to the palliative care team or the oncology nurses because they'll know who is available to support that. Which brings us nicely on to oncology nurses. So you felt that she shouldn't have passed it on to the oncology nurse, she should have asked it herself.
Yeah, I feel as though because there are a lot of unanswered questions from that consultation, it would just end up then the patient probably asking the nurse questions that should have been answered there, if that makes sense.
Yeah.
I feel like they're also experts though, in
Yeah.
terms of dealing with those conversations. And if you have someone like that who's, you know, let's say that is the genuine way that person would do it, is going to do it badly, even if they did stay. Sometimes the oncology nurses are probably going to handle the situation better than a continued bad.
Yeah, no, that's...
So I will always take a specialist nurse with me if I can, because so whether that's a palliative care nurse if they're dying, if that's possible, if they've got time, or the acute oncology nurses who are amazing if we don't know what on earth is going on with them, or the site-specific nurse specialist if there's cancer, because they will know questions that unless you're an oncologist you will not know. So they'll ask you like, what are the likely treatment options, and the nurse specialist will almost certainly know that when I don't know that. what's going to happen to me, what's the next step. And they will, the acute nurse, the specialist nurse will know that, but also they will be following them through that journey, and they will be their point of contact for them to ask further questions. So you've ticked 2 boxes with one thing if you get the oncology nurse to come with you. But she'll also give them a card and say, when you think of questions, phone me. What did she do good?
I mean, maybe I was a bit generous, but she did introduce herself and say hello and try and ask how she was feeling.
She didn't actually say who she was.
Did she have a job?
I feel like she said, did she?
I can't remember.
I remember her saying her name. I was like, oh, as in like she confirmed the patient's name. I don't remember.
She didn't say what specialty or anything.
I don't think she really said anything else about herself.
I don't think the patient would have noticed.
Yeah.
Maybe they knew. Maybe.
Yeah.
Maybe there's a follow-up.
Maybe.
But even on a follow-up, you should always say again in case they've forgotten or didn't catch it the first time. So yeah, create rapport. Introduce. I hate the word stakeholders, but I mean make sure everybody in the room knows who everybody is.
Yeah, open question to start
Oh my
off.
god, I forgot to give out biscuits. You guys have got the dogs, so you get the biscuits first. Just hand them around. Everybody's been very good.
She started off with an open question, which
Yeah.
I think was good because she didn't take too long to get to the Breaking Bad news.
Yeah.
And she didn't just drag on.
I don't know whether it was from awkwardness or not, but she gave the patient a lot of space.
She wants to give Margaret a treat or not. I'll
Should I
keep her away.
say silence? Because that's more clear when people read it back, isn't it, rather than space? Or conversational space. Yeah.
She asked her if she had any questions at the end. But, I mean, she was overwhelmed at that point, but she did ask.
Yep.
She said the diagnosis quite clearly.
Yes, she has the cancer.
Yeah. I mean, she did follow up with like so much more information, which did a lot bad, but she said the diagnosis clearly.
Yeah. Because patients don't understand what lesion means. I was talking to a patient the other day about her known lung cancer, and she was like, oh no doctor, I don't have lung cancer. There's a shadow on my lung. And I'm like, thanks previous doctor for explaining that so well to her. Patients understand what cancer means, they don't understand what lesion, malignancy, mass, neurological disease. They don't understand what those things mean. They don't really understand what terminal means. They definitely don't understand what really unwell means. So what do we all mean by someone's really unwell?
Dying?
Probably going to die in the next 24 to 48 hours, right? That's what we mean. If you ask somebody on the street what really unwell means, they're like, oh, cold so bad you can't get off the sofa. Like, use the words that they're going to understand. Okay. What else did she do? She did do some really good things, right?
She sort of put her hand on her shoulder to sort of try and show empathy, but it made it, at some point I thought it was a bit heavy-handed.
Just like the intent was there.
Yeah.
I wonder if that was also how she was sitting. Was it?
Yeah,
Because
she was above, yeah.
From the patient's body language, I didn't feel very invited.
No.
Like she was like this, and then she just walked past and gave a couple of slaps.
Yeah. It's a bit like a there. Get over it. Yes, totally agree. Touch can be good or bad.
She tried to be supportive. I think we commented on how she was maybe falsely reassuring, but she did try to be supportive at the end.
She booked it was the wrong time scale, but she did book in follow-up and did signpost her to the nurse.
Can we talk a bit more about touch? Margot's like, yes, let's talk about touch. So who here uses touch with their patients?
depends.
Was it you who said you can always like kind of like half-heartedly do it? It's like if you just move yourself slightly closer to them sometimes.
Oh,
And then
in
they-
Don't Teach Them.
Yeah, and then they'll like, then you're like offering them to reach out if they
Yeah.
want to.
So one of the palliative care nurses taught me something. I'm going to use you because if I use Margot, she'll take my hand straight away. So if I'm next to somebody, I'll put my hand here like this, and then you've got the option to take my hand if you want to.
Older ladies do, don't they? They
Yeah.
go to grab and yeah.
But if you don't want to, you just ignore it and I start out. And that's really good because often when we touch people, and I'm so guilty of this because I'm a toucher, is I'll put my hand on top of your hand, which is really paternalistic and can be a bit threatening if you don't like being touched. Or if people are in bed, and again I have to like stop myself from doing it, I'll touch the nearest bit of them, which is their thigh, which is a bit weird. So yeah, that hand that way up within reach of their hand is a nice way because, and also if they take your hand and they're grabbing onto it, it might mean that they want more touch. And it's a nice way, if you're not that much of a toucher, to offer physical support without hugging them if that's not your thing. Okay, good. Just do anything else good? Sure. Fine. I'm going to need some of you who are on that side to move over to that side, or else it's really not fair for the positives. Is anybody on this side feeling a bit negative about life? No, you're feeling really positive.
I'm perfect.
I'm feeling great. There's a dog this time.
Okay. Like you two in the back, do you want to move over to the other side? There's another video. You've got another opportunity to join in. Who doesn't have a piece of paper? I'll just come.
Oh, we're bringing you back.
You might have to share because I didn't rip up enough pieces of paper. Share amongst yourselves. Okay, so we're going to watch her try again. So those of you on this half of the room who didn't catch it, you are trying to find the things that she does well in this Breaking Bad News, and you guys on this side are trying to find the things that she doesn't do very well. Again, those of you coming in late, sorry for the American accents. I can't find an English one that's as good.
Hello, Mrs. Flores. Hello, Doctor. How are you? So I've scheduled this meeting for us today to discuss the results of your breast biopsy, but I've actually given my pager and my cell phone to my nurse practitioner so that we don't get interrupted.
Okay.
Are you alone or did you come with someone?
No, my children had to work today, so I'm by myself.
Okay. So how are you doing?
I still get tired, and I get dizzy if I get too tired. I've got some knee problems, and yesterday I had some nausea. Better today. I think it's probably mostly because of the blood count, the anemia. Okay. So I think I'm okay.
How about any anxiety or depression?
Well, I'm really worried about the tests. I have a lump, so I'm afraid. I don't know about that test they did with a needle.
Have these symptoms affected your life in general, your ability to complete your housework?
Well, I've cut back my volunteering at the nursing home, but I still babysit my grandchildren.
Okay, so my clinic and I can help you with all those symptoms. You know, we'll go over that, at the end of this meeting and in the next couple of weeks. Before we go over the results of the breast biopsy, I would like to ask you one more question. How do you handle medical knowledge? Would you like all the details of your treatment? In my family, my mother would defer to her children, especially me. How do you handle medical knowledge?
Oh, you'll have to tell me. I want to know everything.
Okay, all right. So, Mrs. Flores, I'm afraid I don't have very good news for you today. The breast biopsy revealed that you have an invasive form of breast cancer. I'm sorry. I wish I had better news for you.
How can I have breast cancer? I make all my checkups. I have all my mammograms. I don't understand.
Well, unfortunately, despite routine checkups, cancer can occur in anyone.
How long have I had it?
It's very hard to tell, but you probably have had this for several months.
No one in my family has ever had cancer, except my husband. Could I have caught it from him?
No, cancer's not like a cold. It's uncertain why some people get cancer and others don't. Tell me about your husband.
He died of colon cancer. I nursed him.
Sorry to hear that.
So, I've seen how cancer can eat you up. It's ugly.
I know this comes as a shock to you.
I don't want to be in pain like he was.
You know, my clinic and I, we're going to support you through this, and we're going to guarantee that we address your pain and all the symptoms that you're having. We're also going to be available for your family. Okay? I'm glad you told me how you're feeling, because now I know where you're coming from. The next step is for you to be meeting with a medical oncologist. This is the cancer doctor and the general surgeon. Most likely they'll recommend the following, either to remove part or your entire breast. The goal of this surgery is to remove the cancer. This is going to be followed by radiation therapy and chemotherapy, and the goal is to make sure that we kill any remaining cancer cells that could be present after the surgery. I think we should focus on keeping you comfortable.
Am I gonna lose my hair? Am I gonna have to wear diapers? My children are gonna have to take care of me.
Yeah.
Am I gonna die, doctor?
No, you still have many options available. In fact, I hope the best for you, okay?
I don't want to be in pain like my husband was.
You know, my clinic and I are going to help with any symptoms you may have, including pain. You know, I can help you with all these things. These are all issues that will arise. In fact, I'm a part of a team. In my team is a social worker. A social worker is available to you if you have any financial questions or issues. They're also available to you and your family in the event that you can no longer take care of yourself. They can provide services. And I have a great nurse specialist. She is very skilled in pain management and control of all your symptoms. She's also available for refills. And lastly, my chaplain, he can provide prayer or just basic counseling for you. Are you interested in any of these services?
I don't know about now.
Here's a tissue. You know, I can't imagine how you're feeling, but we're here to support you and we want to provide you with the best medical care for you. We will support you in any way that we can, no matter what happens. Let's plan to meet February 1st. It's on a Tuesday at 9 a.m. So in the next couple of weeks, can you write down any questions that you may have for myself, the medical oncology team? Can you tell me in your own words what I have just said?
I have breast cancer. You're make an appointment for me with the cancer doctor to talk about treatment. But I'm going to get better. But I'm afraid. I'm afraid of what it's going to do to me.
I wish the best for you. You still have many options available, and we hope that we can cure this, okay? And what I understand is that you want to remain as independent as possible. You don't want to be a burden to your family. I can help you with all that. Here is my contact information for you. It has my number and the numbers of all of the people that I just talked to you about. And I have written down the date also of that meeting. Okay, would you like for me to explain any of this to your family?
Yeah,
Okay.
I'll bring my daughter. Okay.
Alright, again, I'm hoping the best for you, and no matter what happens, we're here for you, okay? Alright. Let's talk about your pain. Alright. Tell me when it did start, or...
Unacceptable. I mean, we've all seen them worse than that, though, right? Okay. Do you know what? I'm going to start with a negative. I don't like how she addressed fears that she didn't say. That's me personally. I don't know, when she was like, we can give you care when you can't look after yourself.
I think she escalated the current situation.
Spoke about.
Don't be overly pessimistic.
Yeah. Especially in the first contact.
Do not lie.
When you're going to feel even worse. Let's talk
But
about
there's loads of
that.
options that you want. Yeah.
Let's talk about worst case.
Right, go on then. Hit me with what she did wrong still.
I think she was trying to show more empathy, but her voice remained quite monotonous.
That might be.
That might just be the actor.
Poor
Yeah,
actor.
the other lady was, you could see the emotion on her face. She was really like changing her tone. She was quite soft spoken.
Yeah.
And I think the doctor was quite clear.
Do you think maybe she was?
She had a very long lead up.
Do you think maybe that was because she was trying to maintain professionalism and not cry with the patient?
I think it's a step between crying with a patient and
I don't know. What does everybody think about showing emotion with patients and relatives when you're breaking bad news with them? I mean, it's a good thing or bad thing?
It depends how genuine it is.
Yeah, phone cry. You got cancer. Maybe not.
It's also like, I think it depends on the context as well. Like, if it's someone that you've been looking after for weeks on the ward and they deteriorate, but you've built a really good relationship versus you're breaking bad news for the first time on the emergency floor and you have no idea who the person it is. You know, they're quite different scenarios.
Yeah, they really are. I've definitely cried when breaking bad news more times than I can count. And those ones where I've cried, I've always had really good feedback. Like the relative who was gone to tell the nurses that doctor was so nice and so caring. So I don't think it's necessarily a bad thing to cry on them. But yeah, don't cry. Good. Okay. What else did she do wrong?
Can I just think kind of the question?
Yeah.
I've always tried to avoid, like, there's been many times when breaking bad news where I've had a really difficult conversation. I felt like I've been quite teary.
Yeah.
And I try and do my best to like hold back because I always feel that if I like cry at all in front of the patient or family, then they might feel that I'm not there fully to be this like the person of sort of support and like
The professional who's looking after their relative. Yeah, I know I've struggled with that too. But when I have had to cry, nobody's ever said, don't let that doctor look after my mum, she's obviously incompetent because she's crying. They always feedback that they were touched by how much the doctor cared. So don't worry about it too much.
She spoke about how her family would want to deal with information.
Yeah, she did. It was a bit weird, wasn't it? A bit awkward. But she did ask her how she liked to deal with information, which was, when I first watched these, I was like, I'm going to steal that and put that in my little repertoire. I quite often ask people what level of information do they like to have to start off with? How do they like to process it? And sorry, I'm stealing your points on this side. She did offer for family members to be there. We're running out of space, so I'm just adding them onto other ones. Anything else she still did wrong?
She herself as point of contact. And I don't necessarily think if she would be
It's
the
not good for your own personal well-being.
like if she would be the best person.
No, it's gonna be the acute nurse specialist,
Yeah,
isn't it?
for that.
I think that might be an American thing.
Yeah.
Oh
I
yeah.
think in America the doctors are like contactable.
Yeah.
She almost gave too many contacts in a way. The
So
patient
many
might not-
contacts.
Might not know which one to go to.
Yeah, she's talking about the chaplain, the social worker. They obviously have amazing social workers in America if they can sort out all of their money problems and everything else. But
Like a leaflet is great. We love leafleting, and that's really useful in the scenario for people to refer back to. And
I've got a fun fact about leaflets for
Is that
you.
your read?
No, it's not about that. So, what do people think the average reading age is in the UK? So, the reading age is the level of reading that is thought to be appropriate for each like key stage. So, like what age? Sorry, that makes sense.
Yeah.
Like,
So like
like a lady
reach the
book.
level of a 13-year-old. Is that what you're saying?
Exactly.
Yeah.
So, do you know what the average reading age is in the UK?
I'm gonna guess like
Oh,
13.
6 to 8.
What did you say?
That's terrible.
Isn't it?
What did you say?
Between 6 and 8 years old.
8.
really,
What is the reading? What is that?
So as in, the books that you get from the kids' library that have got different levels of
Yeah.
hardness of word. So the average ability of reading for people in the UK is that they can read age 8 appropriate books. So a lot of our leaflets have got really long words in them, so it may not be as useful as we think they are. But the phone numbers on the bottom definitely will be.
yeah.
I nearly fell off my chair when I heard that. Anyway, right, what did she do good that we haven't already got on our?
Okay.
And she did loads of things that were good. What else can we add to our cheat sheet that we can take tips on?
I wrote pause of processing, like she did one clear, this is bad news, and then pause, which I thought was quite good.
Do you remember the exhaust that you need to pause for a certain amount of time?
You can, yeah.
They used to have thing was like after you break bad news, you have to pause for like, was it 30 seconds? A minute? And you was like, you had to hit the time.
I mean,
In your
that's-
8-minute OSCE, they made you sit.
But she-
But also it's really awkward because you are counting in your head going,
And also, it's an OSCE, you've got 7
It's very-
minutes to break bad news, which is not a plausible amount of time to break bad news. I thought that she broke that silence too quick, though.
Yeah.
But then probably watching a YouTube video would get really boring if she sat there for too long. Because she said, you've got breast cancer, I'm very sorry, which is fine, that was just I feel awkward, I'm going to fill that gap or something. And then and then the patient said, I've got breast cancer, and she started going on with what the next steps were, and I'm like, she's not processed that enough to take that in yet. I'd probably allow more silence, allow more weeping, maybe say something unimportant that she doesn't need to remember first. But, anyway, what else did she do good?
She sat at her level.
Yes, she did. We said about that, didn't we, already? Body language and environment.
she asked if she wanted her to contact her next of kin.
Yes, she did. The family to be there, Emmy said. Off to talk to loved ones.
I think after she broke the bad news, she then, for a little bit, let the patient kind of drive the conversation. She just responded to questions for a little bit, and then moved on to like going back to information giving. And she responded to the cues.
I thought it was interesting at the end, she said, like, what did you take from this conversation? She literally only took diagnosis in the last sentence, and
Yeah.
the rest of the conversation was...
I also don't believe that she took in all that information about the oncologist. That was the actor. But yeah, it felt quite stilted the way she asked, what did you take in? I've still, in 12 and a half years of practice, not found a way to ask people what their understanding was that feels natural and not like I'm grilling you. Margot, that's not polite. You are over-relaxed in this scenario. Anything else she did good that we haven't got written down?
I feel like she tried to be more holistic at the beginning, asking about how's it affected your life, sort of things like just.
And at the end as well, because she was talking about the chaplain and the social worker and stuff. It's not going to be within the realms of possibility for every breaking bad news you do. I really liked how she was talking about her symptoms, and once she followed those cues and she was talking about she was really scared She was scared of ugliness, which she didn't address, and she was scared of pain. And she did talk numerous times about pain and how she and her clinic would help. She did guarantee that they would fix it, which felt like a bit of a false promise, but yeah, and she offered the chaplain, which in America is a very denominational thing, isn't it? But here, you guys know that the chaplains will offer non-denominational spiritual guidance to anybody who's going through any catastrophic or non-catastrophic stuff. So I always offer the chaplain as a good listening ear.
On the back of that, I feel like that she offered the support regardless of what happened. So she made it very clear to the patient that even if, say, you're not for treatment or treatment fails, you'll still receive our care and support, which I thought was nice.
Yes, that is very nice. Possibly a false promise in the NHS and palliative care situation at the moment, but
I was going to say in my head, I was thinking she was like, and
it's
that will
cost. Cool. Has anybody got any things that they think that didn't come up in that they really want to go on the cheat sheet of things that they've picked up through their own practice that they found really helpful?
I think especially when speaking to family members, clarifying their expectations more clearly at the beginning is quite important.
Yeah.
I had a conversation recently where actually the patient's husband said, actually I was expecting you to call me about this, that his wife has died. And I think that actually makes the conversation and what you're going to say a lot easier. Because you don't want to go off on a tangent and the patient's almost going to tell you, I already know this. You know, you want to make it relevant and yeah.
100%, because that's an absolute waste of emotional energy of yourself and not helpful to our relative. And sometimes they'll tell you that they think that their mum's going to live forever, and it helps you frame how you go about breaking bad news as well. Really good.
Often to speak to the family, perhaps away from the patient as well, because they often have more direct questions about timelines and stuff that they don't want to ask in front of a family member.
When I'm breaking bad news to more than one person, they often offer to speak to them separately. So for example, this is just an example, the patient might not want to know their prognosis, but the relative who's their carer might want to know it because it helps them frame it. So I will obviously ask the patient if they're happy for me to talk to their relative in private, but I will offer to, in case there's any things that they're worried about that they don't want to talk about in front of their relative, or we've got it. Do you guys feel a little bit more confident in breaking bad news now? It's definitely an art, not a science. I used to do this as role playing and everybody hated it so much I changed the videos. I hope that you appreciate that you got to sit around and look at YouTube videos instead of doing role playing. Okay, does somebody want to take a picture of it and put it in the F2 group?
Yeah.
I should have put a title, shouldn't I?
I enjoy the example of the manic she's a surgeon.
Oh, no, I can't do it now. I'm trapped.
I tried really hard to make my handwriting legible as well.
I think that they did on Bioworth, because I think often the Breaking Bad News conversations are that they're dying quite quickly, is that they would go through how the dying process would actually look like with the relatives, and they'd be like, you know, at this point they can hear you still, so make sure you're still speaking with them, and then this will happen. I thought that was really nice as a way for the relatives to like sort of deal with the next 24 hours.
Yeah, definitely. Have you ever read any of the books by Catherine Mannix? She's a palliative care consultant who has written lots of books, and she talks, I can't remember which book it is, but it's the one that's like the most popular. If you look on Goodreads, it'll be the one that's at the top. And she talks about how she explains it to patients and relatives, and it's beautiful. It's another one that I've still put in my pocket to to use about like how people get more drowsy and they don't eat and drink, and that makes their toxins go up, which kind of makes them a little bit more unaware, which is part of the dying process, and it's normal and natural, and it's their endogenous midazolam. It's good. Highly recommend reading some Catherine Mannix if you're interested.
What's the surname?
Mannix.
Mannix.
Mannix, I think. Mannix. They'll have it in the library. Cool. Any questions, anybody?
I think, I know we kind of spoke earlier about using like really unwell and stuff in appropriate manner.
Yeah.
For example, if someone becomes like acutely unwell on the ward and you're asked to go and update the family and ask them to bring in their stuff, I always find having that conversation over the phone quite difficult.
Yes.
Because I don't want to tell them their relative is dying over the phone, because that doesn't feel, that feels quite impersonal and thing. But how would you like recommend phrasing that to say, like, you know, we're worried about them, we recommend that you come in? What do you have any buzzwords? Like?
So I would recommend, there are some crib sheets that they made during COVID that I've still seen kicking around on quite a lot of the wards near the phones, which we made to support people in breaking bad news over the phone, because it was like ward clerks who were having to do it and stuff. So they're all over the place, and they're purple with like yellow and pink writing on them, little cartoons. You'll probably be able to find one somewhere. But my top tips for breaking bad news over the phone are: don't beat around the bush, don't use nice words to cover it up, because the person on the other end of the phone does not have the benefit of your body language, and they don't have the benefit of the signposting that you've made of, like, we are having a meeting about your mother's health, you must all sit down in this room and I'm sitting at the same level of you and I got them a big bleep and everything. You're phoning them to say out of the blue. So you definitely don't mince your words. I try and say as few words as possible to get it across, because they won't take that many of them in. So I would say something along the lines of, I'm very sorry to call you right now. I always say, are you somewhere safe that I can talk to you? Is now an okay time to talk? If they're driving, I make them pull over, and I say I'm not talking to you until you pull over. It's quite often a bit of a signpost in itself. And then I will not mince my words. I'll say, your relative has deteriorated significantly. I'm very concerned about them, to the point that I think they might not survive the night, or I think they might die. And I would not shy away from those words, because if you say they're very unwell, they'll be like, okay.
They're in hospital, of course they're unwell, is what I've been met with before. So.
And they've also learned from experience to not tell people whether or not you think that they should come in. They've got to make that decision themselves. And people often will ask you, should I? I'm going on holiday tomorrow, it's a holiday of a lifetime, what should I do, doctor? And my advice to them is always, I can't answer that for you. Which would you regret more? Would you regret missing your holiday and your mum doesn't survive, or missing your mum dying and going on holiday? And leave that to them to make the decision. You can't advise them on that.
Thank you.
Yeah, so in summary, don't beat around the bush, make sure they're somewhere safe. And have you guys heard the sick enough they might die phrase? So there's this idea that if you think that someone is sick enough that they might die, you should tell them and their relatives. Because most people, if asked, would want to know that information so that they can say goodbye to the people that they love, do whatever things they want to do in their last hours. They don't want to not know. Most people want to know. And if you're thinking that someone's sick enough they might die, use those words when you talk to that person or relative, because it adds that element of I don't know, so I can't guarantee either way, because often I've called relatives in so many times and said they're going to die, and then they don't die, and then you're in a bit of a pickle. So if you call them and say they're so sick that I think they might die, that is very clear. It's unambiguous about what the decision they need to make, but it's ambiguous enough about whether you can prognosticate for certain Go forth and conquer, everybody.